my honor today to host this forum, TBMT CAR-T International Forum. Today we do have two speakers. The first speaker will be from Sweden, Professor Jacek Toporski, and the second speaker, Dr. Sihui Li, is our local speaker. The first part we will be speaking in English, and the next part in Mandarin. So first of all, let me introduce Professor Jacek Toporski to everybody. Actually, Professor Toporski is very kind, so he allowed me to call him Jack, and everybody you can call him Jack. Jack actually working in the field of pediatric stem cell transplantation since 1989, so already 30 years so far. And he actually has performed more than 1,000 transplants, including auto transplant, allo transplant, unretinal transplant, and even corporate transplant, and the most recently hepatoidentical transplant. He was initially doing his great job in Poland, and later on invited to Sweden in Lund University Hospital as the head of the transplant, and he's currently in Sweden Karolinska University Hospital in Stockholm, Södertörn in Sweden. Yeah, so right now he's the very senior consultant and also the head in the Center of Allogeneic Stem Cell Transplantation and cellular therapy. And why I invited Jack to meet our members in Taiwan BMT Society, because just last month I met him in Vietnam in the international BMT forum, and during that forum, the Vietnamese director invited a lot of good speakers from the whole world, talking about CAR-T, including Japan, Belgium, France, and also Taiwan. But during that forum, I strongly felt that Jack is the best one to talk on CAR-T, very solid, very comprehensive. So immediately during that forum, I invite Jack to give us opportunity to meet our members in Taiwan and give us this talk. Okay, so Jack's talk for today is CAR-T therapy for treatment of pre-B-cell ALL and diffuse B-cell lymphoma. Jack, please.
Thank you very much, Kevin, for your warm words and invitation. It's a really great honor and a big surprise for me that I have been invited by you, and really happy to be with all of you today or tonight. You know, in Sweden it's 12 o'clock and you have like 7 hours shift. So I do appreciate that even in the evening we can have so many people participating in our meeting. Thank you very much again, and thank you for being with us. So I was asked by Kevin to talk about CAR T cell therapy for treatment of pre-B-cell ALL and diffuse large B-cell lymphoma. And it will be two parts and some considerations about that. And you know that immunotherapy, it's nowadays the newest approach for the treatment of cancer. It's not probably the newest idea, but we have newest concept, a newer concept in immunotherapy. So putting together our efforts to treat cancer, we have, you know, this systemic surgery and systemic therapy with radiotherapy, chemotherapy, targeted therapy like TKI, and then finally the newest one, immunotherapy. And even this approach was awarded by Nobel Prize a couple of years ago, and there was, you remember, the checkpoint inhibitors guys, Allison and Professor Honjo. And actually I met Professor Honjo at the PSYOP meeting in Japan 2018, then he was giving presentation just after he was awarded by the Nobel Prize. What is a CAR T-cell concept? In general, it's like making a living drug. So we're making a drug that we once given, then can be sustainable treatment, sustainable circulation of immune competent cells. CAR T cell stands for chimeric antigen receptor T cell. It's lymphocyte, and the background and the concept behind is that everyone has T lymphocytes, and these immunocompetent cells protect our body against viral infection. But the T cells, lymphocytes, are also responsible for tumor control. So as soon as T lymphocytes stop seeing cancer as a foreign, the cells are not recognized as a foreign cells, the cancer or leukemia can develop. And with the help of gene therapy, the T cells undergo modification, and we force them to regain the ability to recognize and kill cancer or leukemic cells. It's a chimeric receptor, and I will be back like 2000 back before Christ, and then we say, what is chimera? What is chimera? And why we call things chimera now? So the idea of chimera is believed to go back to ancient Greek mythology, and it's often depicted as a hybrid creature that has the head of a lion and a goat with a snake's head for a tail. And it also has been used to mean all fictional creatures made up of several different animals. And virtually this is something that does not exist in the nature, but we just made the myth to scientific reality. We made a T receptor that does not appear in the real life. You will never find such a cell, but we made a new cell, a drug, putting new properties to the lymphocytes. Let's say this is a long story that started in 1989, that were first was double-chain chimeric antibody receptor developed, and that was not so easy to go from these preclinical studies to the clinical application of of CAR T cells. It took, you see, more than 20 years. Then the first pilot clinical trial was completed for patients with ALL and CLL by Rosenberg and Malcolm Brenner. And then we other guys like Jensen and Riedel, and then was realized that it's not, that became reality. CAR T cell therapy is at intersection of the three technologies. For the first, we use the patient's own cells as therapy. So this is a cellular therapy. We insert the genes into patient cells, causing the cells to produce a new therapeutic protein, in this case, chimeric antigen receptor. In the case of B cells malignancy, a receptor that recognizes CD19 protein on the cell surface. And then we use the patient's own immune system, the modified T cells, the immune system component, like a cure for curing the patients. In fact, the concept we have been using for cell therapy is also quite long. For the first, we have discovered T cells like at the beginning of 60s last century, and then we did first allogeneic T cells transfer for solid tumors. We did first allogeneic transplantations, and this just a T cell, just an allogeneic stem cell transplantation. All of us know that it, by definition, have some anti-tumor, anti-leukemic effect. We know that chronic graft versus host disease, a little bit acute graft versus host disease, may possible or may induce longer remission. And we use DLI, of course, for inducing remission in case of relapse after transplantation. It was proven in the CML mostly, but in some other diseases. Then we had DLI therapy, we had tumor infiltrate therapy, we had lymphokine activated cells. That was like the pre-phase of the real CAR T cell therapy that became applicable in the real life at the beginning of 2010, 2011. And that was the first generation of CAR T cells. I will talk about that later. And the second generation of CAR T cell therapy. Then we will also, I will explain what does it mean here on this slide. So the first generation of CAR T cells, that we would like only the better expression of receptor, of T cell receptor on the lymphocytes. That means that the normal lymphocyte get only the receptor and can recognize antigen on the malignant cell surface. It was not enough because we did miss at that time the co-stimulation. We couldn't trigger these cells to proliferate, what was the main obstacle of this therapy at that time. So the next generation, the second generation CAR T cells was not only I'm trying to get the pointer, was not only the CAR T cell here, but was only putting the co-stimulation that could downstream the intracellular signal and force the cell to proliferate, or it was like sustainable proliferation. And the third generation of CAR T cells nowadays being in the clinical studies is just putting two co-stimulatory domains. One, this is 41BB, which is for Kymriah, T-cell, and the other companies using this CD28 co-stimulatory domain. The fourth generation, which is in the future, it would be probably in a couple of years available, that we add additional fragment here that will be able to induce production of interleukins, cytokines that will even enhance the effect of the third generation CAR T cells. They will be more eager, more active in killing. And we have fifth generation of CAR T cells, which we can switch on and switch off. It is quite interesting thing because we sometimes have a way too much of effect. We have toxicities. We can have graft versus host disease in allogenic setting. Then we would like to switch off the cells if they are working too good. So we can put like suicide gene, for example, like Simevan gene, susceptibility gene to these cells. And by giving Simevan, we can switch off the cells by killing the lymphocytes that are for aggressive and harm the patients, not only kill the tumor or leukemia, but can also harm the patient. Let's go back to the indication for CAR T cell treatment in pediatric CD19 positive ALL. I would say there is only one commercially available online on-label product. This is Kymriah from Novartis. Indications is in patients up to 25 years of age, refractory disease, second or later relapse, and relapse after previous transplant. Of course, we can use these cells, CAR T cells, off-label, but I would not recommend doing this unless it's a company-funded trial. We have 2 trials ongoing, ZUMA-4 for therapy-resistant relapsing pre-B-ALL or non-Hodgkin lymphoma, and then Cassiopeia, which was designed for earlier treatment. It was designed for the patients that they are not in the molecular remission at the end of consolidation of the treatment of pre-B-ALL. Cassiopeia is closed, and ZUMA-4 is now on hold because of toxicities, but I do hope that ZUMA-4 will start very soon. Then we can have our academic trials. Let's say you will start the production of CAR T cells by your own, and we in Sweden will start our production by our own, and then we can design our own trials. We can say that high-risk patient, ALL, pre-B-ALL, will not go for the long-lasting treatment with chemotherapy. They will go directly for CAR T cells, for example, at the end of consolidation. Or they will not go for the transplant as is supposed right today, but they will go for CAR T cells. It will open very many possibilities to be more flexible and offer this treatment to a larger cohort of patients. And then, of course, it might be investigator-initiated trials. Then we, together with the pharmaceutical company, agree that, all right, then we can do together. We have an idea, you have the product, and then we go for some kind of collaboration. So CD19, a rational target for therapy, yes. These, as soon as the cells, the malignant cells, express the, let's say, I will do again the switch. As soon as the cells express CD19 antigen on the cell surface, then we can think about applying using CAR T cells, CD19 CAR T cells for these conditions, including acute lymphoblastic leukemia and a bunch of lymphomas. So this is the real application for this specific product, CAR T, CD19 positive, CD19 directed CAR T cells. And what happens here? So we're supposed to give one time treatment with a living drug, as I said. So we do apheresis first. The patient cells are going to the production center, and there are 2 centers in Switzerland and the States for Kymriah. Then we can do this lentiviral encoding, introduction of CAR, the receptor into T cells in the lab. Of course, if we are able to produce our own CAR T cells, it will happen on site in Taiwan or Stockholm. Then we can do, we have these T cells expressing CAR, then we expand them into the lab and make millions of identical copies. And then the cells are transferred, frozen, transferred back to the treatment center, and we do the treatment. And the treatment is always like that a couple of days or 7 days before CAR T cells infusion, we give the patient an lymphodepletion, which is called, but usually according to Kymriah treatment protocol with fludarabine and cyclophosphamide. Then after 2 days, after finishing this infusion, we thaw and infuse the CAR T cells. Then we have this very good, they are modified and reinfused for CD19 targeted killing, and you see the same leukapheresis, and the cells proliferate in vivo and recognize and eliminate the tumor and other CD19 expressing protein expressing cells. So this treatment is directed not only specifically for leukemia cells, it will also kill the normal healthy B cells, and it has some consequences. as I told at the beginning, showing the different generations of CAR T cells, this, which is very crucial for this product, is this co-stimulative factor, co-stimulative domain. So it enhances early expression and long-term persistence of CAR T cells. So after infusion, as soon as the cell is targeting a CD19 positive cell, they expand and they stay in the circulation for a long time. And even if the target disappear, then we can have induction of central memory T cells that will help in case of relapse. These memory cells can be activated and proliferate again. And these transgene level of CAR T cells are observed up to 2 years after infusion. I've checked, like yesterday, there was a 1-year control post-CAR T cells in my patient, and the patient has 8 CAR T cells per microliter, being in complete remission 1 year after the transplant, after the CAR T cell treatment. So this is persistence and early expansion, or early persistence, or persistence. So what do we have the additional options, and why do we really need the CAR T cell approach? You know, with nowadays protocols that we are using in Sweden, we have this all-together protocol, and different countries or different regions use different protocols. We have successful rates to treat the patient according to the first-line treatment, to cure the patient, like 80%, but 20% fail to be cured by the first-line treatment. So then we are looking, is the patient is eligible for the stem cell transplantation or is not eligible for the stem cell transplantation? If the patient is not eligible for the stem cell transplantation, then we can have that CAR T cells is additional treatment option for patients. Receive a one-time treatment, don't need to complete remission. This is very important. We don't have these patients being in the remission, and no donor is required, which is obvious advantage over the allogeneic stem cell transplant. But even though some group of patients goes to the transplantation, then some of them have relapse, and then this is also a clear indication for CAR T cell treatment. So these guys, again, they don't have to be in remission. They can have 60, 70, 80% of blasts at the time of CAR T cell treatment, infusion. Then, of course, this treatment is associated with specific adverse effects. The first is, which is called cytokine release syndrome. It generally starts within 1 to 10 days, with median onset in 3 days, and median time to resolution is like 8 days. And these effects of cytokine release syndrome are fully reversible. I told you that the ZUMA-4 is on hold right now, and what the reason is that there was a unexpected death because of the cerebral edema, and now the study security, all the guys are responsible for safety, are just going through and analyze the case. But it may happen, not very often, but this is a risk. This is a risk. And then we have neurotoxicity, which we call it for ICANS, which is immune effector cell associated neurotoxicity. One thing about CRS, this is often thought to be related to the tumor burden. We say more blasts in the patient, 80%, then the risk for CRS is higher. MRD, like 0.01, there probably no CRS, or very, very low, very mild CRS symptoms. The reason for neurotoxicity, back to the neurotoxicity, is unknown. The standard care is supportive, and the treatment with corticosteroids, this is the same like the treatment of CRS, which is tocilizumab or corticosteroids. Median time for onset is 4 to 8 days, and duration is 3 to 13 days. It's also reversible, but it's really life-threatening condition. And you see toxicities by organ system, you name it, you may have any organ you have or any tissue you can imagine, they can be affected by CRS. We usually go in that way that as soon as we know that the date for the CAR T-cell treatment, I inform ICU and neurologist, and we are ready to take to move the patient from our department to ICU or pediatric ICU if needed. We must secure that there will be the place. We must secure that there will be available pediatric anesthesiologists that will help us even in the middle of the night. So we really do a lot of networking and collaboration before we start the treatment. And this is typical example. How does it happen? What happens after CAR T-cell treatment here? Then we have temperature. We see the first rise of the temperature like 2 days after infusion. We already here we recognize that this is probably CRS grade 1, and the patient was given tocilizumab at that time. Still temperature, high temperature. We see rising interleukin-6 and rising ferritin later on. So there was 3 doses of tocilizumab, and then it calmed down. So this is example how this is the reason for this is that the dramatic proliferation of CAR T cells and dramatic cell killing of the tumor leukemia cells and the cytokine storm, and then it calms down. And this patient is actually in remission quite for a long time. So definition, fever more than 3 days. We usually act early. We have learned us that it's as early as better. So we go for the treatment as soon as we have the fever and we have no other reason for fever like infection. Elevated serum cytokines, we usually look at, this could be different, but we usually look at interleukin-6, systemic toxicity, and the symptomatology that we have hypertension, hypoxia, neurologic disorders. And it was, I told you, it's reversible, but correlates with the tumor burden. And there is another option that some patients with MRD, a very low MRD, they probably could be treated as outpatient. Now we have the patient on ward 10 to 14 days after the treatment. So it probably could be shorter time for hospitalization. This CRS can be abrogated easily or more or less easily with tocilizumab or corticosteroids. Long-term effect is B-cell aplasia, because as I told you, they target not only tumor leukemic cells, but also healthy B cells. And some patients may, all the patients really have to be on IV replacement therapy. B-cell aplasia here is all patients suffer or experience B-cell aplasia. This is a marker that as soon as we have B cells recovering after CAR T cells, then we can assume that we lose the function of CAR T cells. So this is a warning sign, not only for losing the function, but it's also a warning sign for relapse, like imminent relapse, when we see that B-cell aplasia disappear. Tumor lysis syndrome, yes, that depends mainly in the patients with chronic. This is about the adults. Macrophage activating syndrome, yes. On neurotoxicity, as I told you, in form of these icons. Then tocilizumab is a treatment, is a drug of choice. It's not the new drug on the market. Typically, in these conditions, is given once monthly, but in our case, we do this like maximal 4 doses, 12 milligram per kilo. The shortest interval between the doses is 8 hours. Then it will be a little bit about, I will speed up a little bit about the only presented data on efficacy and safety of CTL of the T-cell letrozole in pediatric ALL is the ELIANA study, putting together 25 sites across 11 countries in all over the world. Then we had the inclusion criteria. You see more than 5% of blasts are kids. We have the endpoints, and this is the lymphodepletion, as I told you, fludarabine, cyclophosphamide, and Kymriah, and a single infusion. Then we have they have screened 113 patients, enrolled 97, and you see that 18 patients didn't get the treatment. There was manufacturing issues, and in 10 cases, the disease were too fast and killed the patient before we can give the treatment. And then in the follow-up, we have 45 patients. And here on the right side, you see the product, the Kymriah, how it comes from the manufacturing. Then patients, which is quite important, 61% had been previously transplanted. We had relapsed in CR1-4 patients. We had refractory and relapse disease in more of the cases, and some of them have also genetic lesions, features for high risk. And then you see by this, that this is a group of very, very high risk patients, virtually with no chance to survive without this treatment. And then what is very nice curve, we see the relapse-free survival is more or less, does not change very much from the month 12 to 2 years after the treatment. Then we have 62, 66%. I do hope that this data will be soon updated. One more important thing here is that the patients that have been MRD negative and day 21 after CAR T cells, they are doing much better than compared to the patients that have not been MRD remission day 28 after the CAR T cells infusion. So this is also good, factor that we can expect that the patients in the MRD, they will do much better than those that didn't have MRD negativity 4 weeks after CAR T cell treatment. Cytokine release syndrome, you see all of them, 77% of these patients had some kind of CRS. The most common was, the duration was 3 days, onset was the day 3, duration 8 days. 50 patients almost finally were treated on the pediatric ICU, and the treatment was like 3 doses of tocilizumab in 4 cases and so on. Hypertension, 33, intubation, 15%, dialysis, 10%. So this is a toxic treatment, and you really should be prepared to acute measures when the CRS appears. Okay, I think that we can skip this and we go to conclusions that with high efficacy observed in updated analysis consistent of previous report, 82% achieved complete remission without hematological recovery, complete hematological recovery, and 19% were MRD negative flow cytometry. So durable remissions are observed with relapse-free survival and overall survivals. And this is definitely the important thing, that T-cell letrozole Kymriah offers a new option for pediatric and young adult patients with refractory resistant B-cell ALL. Now we go to lymphoma. I know that, Kevin, you have been interested in lymphoma. So just, I did, because we don't have a big experience in lymphoma, because it's not a label indication for pediatric lymphoma, and we don't participate in any lymphoma studies. I just did a screening, and then it comes here that so far no label indication for pediatric lymphoma. And this is the one important thing, that pediatric major, BNHL, and pediatric B-cell precursor ALL are distinct diseases. It's not the same. They don't behave in the same way. Most pediatric B NHLs are Burkitt lymphomas, which are rare and have excellent prognosis. The relapse disease has poor hemosensitivity and very poor prognosis. And many potential medicinal products for B NHL, and in the view of the very small population and randomized study, this is not feasible just to start this treatment option. Off-label used within the framework of the clinical study is the Bianca treatment with the indication like Burkitt, diffuse large B-cell lymphoma, primary mediastinal B-cell lymphoma, gray zone lymphoma, follicular lymphoma. This study is active, not recruiting, no published data yet. We do hope that it will happen very soon. And this is also targeted for population with poor prognosis and lack of approved effective therapies in this setting. And again, academic trials and investigative treatment trials, that's up to us. That CAR T cells in lymphoma outside Bianca, there are some data that in contrast to B-cell precursor ALL and also adult diffuse large B-cell lymphoma, the general picture of early experience with CAR T cells in relapsed refractory Burkitt is of no response or early partial response followed by rapid progression in the majority of patients. So this is a problem. It's not like we can just estimate that we have excellent results in pre-B-ALL, then we have also good results in B-cell non-Hodgkin lymphoma. No, that's not the case. We don't know what the mechanism of resistance. What the best targets and is a dual triple targeting required to optimize therapeutic response. I mean, that could be CAR T cells targeting two proteins, let's say CD19 and CD22 in one cell. And what are the comparative benefits of CAR T cells versus other treatment options? We don't know. And should subsequently hematopoietic stem cell transplantation be utilized to consolidate this response, this partial response? So there are some data, some facts that we don't know. Competing approaches in pediatric lymphoma, we have these antibody drug conjugates, we have CAR T cells, we have monoclonal antibodies, we have BiTEs, we have checkpoint inhibitors, and we have these cell signaling inhibitors. So you see a branch of different options, and this is very small population. So I don't think we will conclude quickly or easily what is the best option to try. Or doing this in the randomized manner, it's probably not possible. So we should agree what we should go for in specific regions, countries, or societies. But I think there's so many competitive approaches in pediatric lymphoma that the role of CAR T cells, it's very difficult to be defined. And then, what it's about adults. I would like to show you that there is a fact, and that's why you are so keen to test this treatment also in pediatrics. We have an adult patient with malignant tumor here, B-cell lymphoma, diffuse large B-cell lymphoma, and then 15 months after, the tumor disappeared, and that was the only treatment. So this is a very good example that it worked, but it's not a pediatric case. And we have another one here, that it was mediastinal B-cell lymphoma. The patient is 42 months after CAR T cells, 23 months after CAR T cells, there was no tumor. So it works. We see this. Definitely the adults. My department is a combined department treating kids and adults at the same ward. So I see the adults getting better and being cured after CAR T cells. But since I have been here in Stockholm like 3 years, we didn't have any candidate, we didn't have any child that could be a candidate for CAR T-cell with B-cells, B-cells lymphoma that could be a candidate for this treatment. So this is really very rare disease. Then we have examples of CAR T-cells clinical trials, because we are not only interested in B-cells malignancy, we have also different diagnoses, and as a pediatric oncologist, I'm particularly interested in neuroblastoma, for example, and Ewing sarcoma. These are the neuroblastoma here, glioma. These are the drugs, the targets for coming CAR T-cells. In adults, there is a little bit more, because now we have not only pre-BALL, not only B-cell lymphoma, but we have also multiple myeloma. We run this treatment also here in Karolinska for multiple myeloma patients, which is basically diagnosis for the adults only. So what we have more here? Considerations, yes. Chimeric antigen receptor T-cell therapy has a substantial promise for children and adolescents with cancer. It's a broad cancer. I mean, now we test in the very selected one indication. However, there are biological, clinical, and manufacturing challenges. Yes, we have to send this, we have to collect, we have to transduce, we have to have effective expansion and manufacturing and the central manufacturing. Strategies must evolve to ensure appropriate access to these novel treatments. This is a big discussion. Who is going to finance these? In Sweden, this is like a standard of treatment with on-label indication, clear, but not in very many countries. Comparative benefits of chimeric antigen receptor T-cells and adoptive cells therapies need to be evaluated. We don't know, is this the only treatment that we can offer? Maybe there is something different, like BITE, for example. Strategic, scientific, regulatory, health technology assessment and funding requirements should be aligned. So yes, this is what I've been talking, like academic studies, own production. This is very important, that we will not be depending on the centralized production and certain slots and central indications, but probably we could do the treatment like is here, moving beyond currently approved indications. I really suffer when I have a kid with high-risk leukemia and I say, okay, there is a fine treatment, like CAR T-cells, but you are not sick enough to get this treatment. You have to be more sick, and I go through the intensive chemotherapy and maybe stem cell transplantation, and then if you relapse, then you will be candidate for CAR T-cells. It's not good for me. I feel myself not well in such discussions. Burning questions. Is CAR T-cell therapy a definitive therapy for pediatric ALL? Yes, perhaps. Perhaps. We don't know. We still have the relapse-free survival, according to Eliana study, like 60 to 66%. So probably it's not. For some patients, it's definite therapy. Is CAR T-cell treatment a bridge to transplant? Yes. It may be, because we have some patients that are never go to remission. They have still some amount of leukemic cells on their ongoing treatment. They are not in MRD remission, and we know if the patient is MRD positive above 0.1% MRD pre-BLL, that the risk for relapse after hematopoietic stem cell transplantation is very high. So maybe we can induce and bridge the transplant, the patient with CAR T-cells, induce a complete remission with MRD negative remission, and then go for transplant. That probably the chance, the risk for relapse could be lower, but we need to test this concept. Can we predict the success therapy when we start? Yes, very too low tumor burden, it's probably good. We don't know. We know that these patients probably will be cured by a single infusion of CAR T cells, and the high tumor burden probably will need will need additional treatment after CAR T cells. Again, maybe transplantation will be beneficial. As I told you before, the B cell recovery usually precedes measurable MRD. We can monitor T cells. Usually, as soon as we have circulating CAR T cells, there are still in B cell aplasia. But we know, again, like in the next point, that we can have CD19 negative relapse and that it will not work if we do reinfusion. We have to have another option for the first for relapsing patients or the second for CD19 negative relapse. It has been already discussed that probably it has an option because we can bridge to transplant, or we can do the transplant when we see the patient relapsed. We can do again if there is a CD19 negative relapse, and I have a couple of such patients. They had CD19 positive relapse, and they get second infusion of CAR T cells, and they go to elective transplantation after second infusion of CAR T cells. And there are both of them. I had two patients. Both of them in a long-lasting remission. And this is the thing that I'm really keen to explore. Maybe this is a place for CAR T cells earlier in the treatment of PB. Maybe for selected group of patients, maybe for Down syndrome, maybe for high-risk patients. Maybe if the toxicities are there's too much toxicities, so it could be probably the option for another group of patients. So with this, I would like to end and thank you very much for your attention.
Okay, many thanks, Jack. The wonderful, comprehensive, and a very solid lecture. Today, we also invite several experts in Taiwan. First one, Dr. Zhang Xiuhao. Dr. Zhang is from National Taiwan University and also pediatric hematologist at SU. And the second expert, Dr. Ye from CMUH. And the last one, Dr. Lin, he's a biotechnology researcher. So they are all our panelists. And all the audience are also welcome to ask a question by typewrite your question. So does anybody have a question for Jack, our panelist? Okay, Dr. Zhang, please.
Yeah, thank you, Jack. Very nice talk and very comprehensive. And I have a question about what is the optimal bone marrow blast level for the CAR T therapy, because some people say if the bone marrow is too much blast, of course the CAR T therapy effect will not be very good. But if the MRD is totally negative, maybe they will also affect the CAR T cell proliferation. And do you have any comment on the optimal bone marrow blast cells level for the CAR T therapy?
If I understand you correct, there are two things. The first thing is to do the apheresis in the right time point, because the quality of collected lymphocytes then undergo production is crucial. So we should avoid the drugs that can interfere with the T cell function and number before we do the leukapheresis for CAR T cell production. This is number one. And usually we would like to have more than 300 of T cells in the per microliter blood when we do the harvest. This is number one. And then we should avoid, cortisone. We should avoid toxicities. We should avoid other drugs that interfere with the T cells function. The second thing is the optimal number. Yes, I know that people say that if you have MRD negativity, that there is no target for CAR T cells, which is only partially true, because usually these patients have anyhow normal B cells, which are also the target for CAR T cells, and also can induce the proliferation of in vivo proliferation, in vivo expansion. So we do have some effect of CAR T cells. So I know that negativity, if the patient, okay, we have a patient with the indication for CAR T cells, we are doing quite well, we do the harvest, we do the bridge to CAR T cell treatment, lymphodepletion, and the patient is a memory in remission just before the infusion. We go for the treatment anyhow. So we don't say, okay, there are no blasts, the MRD is totally negative, 0.001. No, we go for the treatment. The second thing, there is no such, never we can say whether we have too many blasts. We can have 90% of blasts, we can have 60% of blasts, and we can go for, so there is no upper limit. The only limit is that we probably will induce substantial toxicities with a high risk for CRS or high risk for ICANS. But there is no need to give any additional anti-leukemic therapy to lower the number of blasts to a reasonable level. So 60, 70, 80 is acceptable. I mean, we'll go. We will not do anything else just to lower the blast number. If it was the answer to your questions. If not, just clarify, and I will do.
Just because some studies show that if the tumor burden is very high, then the CAR T therapy effect will not be very good. Do you agree with that?
No.
Okay. So you think even it's totally frank-related, or even 100% is also good for the CAR T therapy?
There is another thing, not only giving the treatment, but there is another thing that we are looking for is a general condition of the patient. And I would say the patient should survive a couple of weeks even without the treatment. And of course, if the patient has extremely proliferating disease, that we usually try to lower the number if in this period between lymphocyte collection, between apheresis and the treatment. We usually have 4 weeks to do something to go down with the number of blasts. And I have never been in our cases putting together adults and children that we really lose control. If we lose control, that the patient virtually dies. I mean, there is no perspective. So it's a hypothetical case that we really have 100% and nothing what we do will help. I have never been in such, in the clinic, I have never seen that. But again, I think if the patient is fit and we think, okay, he will survive a couple of weeks, then I will go for lymphodepletion and go for CAR T cells. I don't think this is the only risk I see is not that the CAR T cell will not work. I see the really high risk for life-threatening CRS, tumor lysis syndrome, and ICANS. So this is the thing that we should have into consideration. Is the patient fit enough to survive CRS?
Okay. Yeah, thank you.
Dr. Lin, Dr. Anthony Lin, do you have any comment for Jack's speech?
I think that even patients who have extremely high leukemia cells, they may respond to CD19 CAR T treatment. However, I think that the response durability is a little bit different because I think that there is no exception that patients with higher tumor burden to have a higher relapse rate. Yeah, I think this is my opinion. And if we go back to the extremely low minimal residual disease patients, sometimes I wonder that because CAR T cell need to meet the cancer cells, and then they can proliferate, expand in vivo. So if there is not enough CD19 positive cells within their body, then the CAR T proliferation and the expansion is not so satisfactory. So it may affect the it may have a negative impact on CAR T cell persistence. This is my personal opinion. But I do agree that we need more experience and see how we can make a final conclusion. Yeah.
I totally agree with you. But these patients, I told, they have quite often, anyhow, they have B cells, like low numbers or whatever. So the regular, normal, healthy B cells, if usually, so some target, if you are so effective at killing leukemia before CAR T cells, then we still have some amount of target, which is not the leukemic cell, but is a normal B cell. And of course, it's like a speculative, because we don't really know. Sometimes we are very effective in depleting also normal B cells. But I think because there is no option, so I think I would go for CAR T cells also if the patient turned out to be totally CD19 MRD negative. I would go for that. You know, usually when we produce the CAR T cells, we have 2 or 3 bags of the product. So we usually have one bag of the product, and we still have something in the production facility in Switzerland or the USA. So we did a couple of times reinfusion of CAR T cells while when the patients became positive after the first infusion. So we did retreatment with CAR T cells, and then electively we transplanted the patient between 4 to 6 weeks after the second CAR T cells infusion. So we will achieve a very good MRD negativity and go for transplant, even if it was the second transplant.
Okay. Dr. Ye, any feedback to Jack?
Question for you, because lymphodepletion chemotherapy is very important for success CAR T therapy. But in some protocol, in some study, if the patient or total white blood cell count, for example, less than 1,000, then we can skip the lymphodepletion chemotherapy. So my question is, if a patient, maybe because of the bridging chemotherapy before the CAR T therapy infusion, but before we get the CAR T cells, but the patient have persistent leukopenia, for example, white blood cell count roughly around 1,000. So in this situation, will you skip the lymphodepletion chemotherapy or using relatively low dose depletion chemotherapy? What's your opinion?
This is a very good question. So why we are using lymphodepletion chemotherapy? Lymphodepletion chemotherapy is not targeting leukemia.
Yes.
Lymphodepletion therapy is targeting patients' normal lymphocytes that can interfere with the infused CAR T cells, which are a foreign construct. So we will prevent that the patient's lymphocytes will kind of reject the infused cells. So this is the reason for lymphodepletion, not to target residual or not residual leukemia. This is just to facilitate work for CAR T cells. So I wouldn't skip it.
So if you give the patient, if for example, if a patient have only 1,000 microliter white blood cell in the blood, and if you still give a standard fludarabine and cyclophosphamide lymphodepletion chemotherapy, will this treatment induce prolonged neutropenia or even more aplasia after the CAR T cell infusion?
So I think that 1 gram cyclophosphamide per meter square and let's say 120 milligram of fludarabine, it will not produce sustained marrow aplasia. But there is another point which is very important what I didn't mention. If the patient develops CRS, which is lasting quite a long time, that is probably activation of macrophages in the bone marrow. And this is, as a result, almost all the patients which had severe or mild to severe CRS, they usually have prolonged cytopenia, mainly thrombocytopenia and neutropenia, which is not connected to leukemia, which is not connected to the treatment, but is connected to the damage of the structure of the marrow that will not allow prompt or proper hematological recovery. It will take much longer time and they finally will recover. Sometimes they need Neupogen once per week just to keep the neutrophils up to 500 microliters. But it's not about the leukemia, it's not about the treatment, it's about the real damage of the architecture, of the structure of the marrow.
Okay, thank you.
Okay, Jack, okay, Dr. Lin.
Okay, I want to echo Jack's viewpoint. I think one of the most important goal of lymphodepletion is to make a small scale cytokine storm so that patient may have interleukin-7, interleukin-15, or something like that within their body. So when CAR T cell infuse back to the patient, then they can find their food, or their energy of CAR T cell within the patient's body. So I think lymphodepletion is inevitable. Maybe you can adjust the dosage, but I suggest not to totally skip the lymphodepletion.
Jack, I think you can read our audience has a question for you on the list. Could you comment about future generations such as tandem CAR or bispecific CAR T cell therapy in the future? Okay.
The tandem CAR, I think they have just been exploring some preclinical studies. I mentioned that this is probably the approach that we can use in the lymphoma, which the regular CAR, pediatric lymphoma, which the regular CARs are not so effective. And then we can probably prevent the tumor escape, so we can target CD19 and CD22. Now I have seen the clinical use within the clinical trials, CD22 CAR T cells, while there was CD19 positive relapse. But the tandem CAR T cells are a very good option because we can target cells with different expression of protein on the cell surface. So probably we cover better the leukemic population with CAR T, with double. And the second was, what was the second approach? There was about CAR T cells and another indications. Yes. I think that it would be very interesting if we could target T cells in some way, and I think there are some ongoing clinical trials targeting CD5 or CD7, which is quite interesting. Now I have a patient that is a very good clinical condition, and we cannot put him in the remission. He's relapsing all the time with the T cells, with the T-ALL, and we cannot go for the transplant. So this refractory T-ALL is a real clinical problem. There are the myeloid target is not so easy because we can cover the normal hematopoiesis, which is quite quite a complication. I'm aware of ongoing studies. I think it's in Rome that my colleague Franco Locatelli is doing some clinical trial with neuroblastoma cells, targeting specific antigens on the neuroblastoma. I'm aware of the ovarian cancer in adults, that they are targeting the cell specific for ovarian cancer. I know that there's also preclinical study targeting Ewing sarcoma. So this is what I know, what is on the shelf, on the table right now. It's probably when we will just to like to make some kind of what we can expect in the future is let's say we can construct a specific target for a specific patient, for a specific leukemia type. This is this precise or medicine or individualized cancer therapy. It's probably science fiction right now, but a couple of years there we didn't know anything about targeted treatment, and now we do the analysis of the tumor and trying to find what the kind of drug could be more effective. So probably we could. This is probably the future, that we can construct CAR T cells directed specifically to the patient. Another option is probably, which is also I think ongoing, if we could do, let's say, third-party CAR T cells that will be not recognized by the patient's own immune system. If we could hide HLA antigens on the cell surface, so they will be neutral for the patient's immune system. And then we avoid the question of expansion and long-lasting production and collecting adequate number of a sufficient number of well-functioning T cells. So this is also quite an interesting concept for the future. And then finally, if we can put the switch off gene in the third party, for example, then okay, we see graft versus host disease of CAR T cells after infusion of third party CAR T cells. Then we can switch them off by CAMPAT, for example.
Okay, so many thanks to Jack. Because limited time, I have to let Jack to have your lunch, because time difference is 7 hours. So
Yes.
right now it's 1 p.m. in Sweden. But
Yes.
but Jack, I think I have a very good recommendation for you and our member. I'm suggest today is just your part 1 lecture, okay? Because we actually have so many questions. So maybe 1 or 2 months later, we arrange part 2 for you. And at that time, that's QA section. We may prepare, say, 20 questions and email to you first. And one by one, we squeeze your knowledge and experience, okay?
I'd love it. I'd love this concept because, just giving a presentation is not only the pleasure to talk to you,
yes,
but
okay.
it's a kind of behind to prepare to say something, to say something stupid, I would say. So it
Okay.
also forces me to, let's say, to go deeply in the daily work. So don't just rely on my feelings, but try to find data and really go deep into details. So I do appreciate. Otherwise, I wouldn't do that because I'm so lazy. So
Thank you.
it's great. It's really great to have this interaction.
Okay, thank you. Okay, so then Jack, you can be offline and goodbye. Goodbye.
Thank you very much.
Thank you, Jack.
Bye, guys. Thank you very
Bye-bye.
much. Thank you.
Bye bye.
Bye.
好，那我们现在就走到我们第2个部分哈，那我们就请到我们最熟悉的柯博生前理事长哈，也现在我们台大 IE 的主任哈，柯主任哈，来帮我们 host 第2个 section 哈，来柯医师请。
线上的各位大家好，那我们就改成中文哦。好，那我们今天第2部分的演讲，我想是请到李思慧医师。我想李思慧医师大家应该也不算陌生啦吼。那李思慧医师是台大的训练的医师， 在台大医院接受完整的内科、血液科，还有移植的训练，那同时也有临床病理训练。那之后呢，短暂时间到台城细胞治疗中心，那现在是回到台大医院综合诊疗部的细胞治疗科。那其实李医师那在这段期间当然协助了包含癌症医院还有台大医院的一些细胞治疗中的计划的建制。那当然台大医院的几个CAR-T 相关的一个治疗的案例，其实李医师也都有相当程度的参与其中。所以今天就请李医师来跟我们介绍一下。那其实我想主要是在台湾我们怎么样去 implement 我们的 CAR-T therapy 在我们的临床的病人上面。李医师请。
各位先进前辈老师大家好。那很感谢就是柯博生主任的介绍这样子。那今天很荣幸跟大家分享一下，就是我们在台大医院就是还有癌医在建制就是 commercial CAR-T 那台湾第一例的就是 Kymriah 的一些经验这样子。好，那就是其实就是要执行 CAR-T 的这个治疗呢是没有办法一个人完成的这样子。所以这张 slide 是我截录那个 clinical options clinical care options 的 slide， 就是因为我觉得它做的很精美，它是导入了 Memorial Sloan Kettering 的 CAR-T program 呢，就说到从 patient 的 intake 就是从病人转介到就是病人要进入 consultation。那screening 过就是patient selection 的部分呢，到cell 的 collection， 那在等待细胞回来的过程，评估病人是否需要 bridging 到 infusion， 到infusion 完的 early care post late 就是 post CAR-T infusion 的late care， 还有其中就是因为这个治疗它非常的昂贵，而且很新，那又牵涉基因改造，所以会有很多后端的一些就是 post marketing 的 monitoring， 就是法规要求我们做的事情。所以它其实是需要有很多就是不同领域的人一起参与，才有办法把这个治疗就带给病人这样子。那就是这张 slide 其实是我在那个英国的那个他们的就是再生医疗的就是讨论会看到，我就觉得就是还做的还蛮好的这样子。就是一个CAR-T 或者是一个 cell therapy 应该是说对了 CAR-T 就是 cell therapy， 它主要我们可以分成两个 part， 一个就是所谓的 patient journey， 从得到病人的 informed consent， 那在病人在门诊或在住院我们 assess 病人，到我们跟实验室沟通我们要什么时候收血球，那要收几个疗程，那在等待 CAR-T 回来的时候呢的 disease evaluation， 然后pre-CAR-T 的 lymphodepletion administration， 还有 toxicity 呢，就是一个很漫长的 journey。那 product 的部分呢，其实也是一个很漫长的 journey， 这样子就是从因为这个 cell therapy， 刚刚前面的讲者有说它就是一个 living drug， 它的 starting material 就是从病人身上来的，所以starting material 当然是决定这个药物治疗品质最重要的一个东西嘛，所以我们要怎么取得品质最好的原料呢，是很重要的这样子。那就是因为收集完以后我们要做一些处理，因为毕竟细胞是要送到国外去做制造，所以需要冷冻保存，然后要调整细胞的浓度。那病人回来以后呢，要签收。那其中最重要的就是因为这个病人这个药呢是就是标准的personalized medicine， 因为你不可能拿 A病人身上的 T cells 输给 B， 所以整个过程它的所谓的 chain of custody、chain of identity 就变得非常重要。那细胞解冻，细胞的就是分配，就是分发，还有输注呢，又是另外一个 journey。所以两个 combine 在一起呢，其实是需要很多的沟通，就是各部门、各单位人员，就是沟通的。才有办法 success 的 bring to patient 这样子。那主要切 pre-infusion 跟 post-infusion， 因为我们还没有 infusion 前，我们要先从病人身上得到 material 嘛，所以医师端要跟 跟实验室端还有厂商端呢要有非常密切的联系。我们要跟实验室说我们要几月几号收血球，要收几个 cycle， 那几月几号要请厂商派就是 steward 或者是派就是那个 logistic 的送货员来把就是细胞带走这样子。那当细胞回来以后呢，输注当然就是医师就占很重要的角色。那除了 hematologist， 那还有就是 ICU 的，因为 CRS 有时候就是会非常严重，那甚至neurological 的neurologist， 那还有radiologist， 那就是各专科其实都需要。那当然医疗就是协助单位像药剂部啊、护理部也扮演非常重要的角色。那 post infusion 最重要就是有很多法规我们是需要去做，给这些病人在接受这些比较新型的治疗做一些安全 long term 的 follow， 所以有一些 data 需要收集，然后要回报这样子。所以在台大医院我们虽然 CAR-T 的case number 不多啦，不过就是并在那个 BMT conference 有一个所谓的多专科的会议，那会议当中就会有医师，主要就是血液科的医师，那护理的人员，实验室就是专门在收集细胞、处理细胞的医检师，还有实验室的医师，还有药师，会一起共同来参与CAR-T candidate 的 discussion， 那会一起 review 这个病人的 indication 啊，适不适合做，还有一些病人有一些特别状况，例如他 CNS 有的，那他未来发生CNS 的 complication ICANS 甚至 cerebral edema 的机会是不是很高，那我们是不是要事先做什么 prepare。 那这一次我有加了一些就是我从 ASTCT 的 CAR-T working group 截录的一些就是 education slide， 那它其实也是有一个 series， 有一个 module 呢是在专门在说怎么 success 的怎么成功的把 CAR-T 的治疗推广到就是不同的 institute。 那其实最重要的就是你要有一个CAR-T 的 team 这样子，那就是因为其实我相信不是每一家医院都像台大医院这么 luxury， 我们就是有我还有我们单位还有另外一个儿科医师叫杜医师，是专门负责院内的 CAR-T 的窗口这样子。那有很多医院当然就没有一个这样子的专责医师，所以常常都是其他他有需要忙其他临床业务的医师，那又要花时间来做这个部分，就会很辛苦，因为做 CAR-T 就是有非常多的行政，就是需要去做沟通的这样子。那目前就是我们还没有，不过未来我们是希望有机会有的，就是有 coordinator 的角色。那刚刚前面有讲到，就是 ICU 啊 neurology 其实是我们很重要的就是专科医师，对，那药剂部啊，还有就是实验室的部分。那这也是就是那个刚刚讲的，就是 CAR-T working group 揭露的一个 best practice 啊，就是他们建议就是 experience 的 center 应该要有这一些，就是有 dedicated team， 那有很好的 referral， 那因为毕竟这个治疗大家听到都很 fancy， 觉得很有希望，那所以你要跟病人解释的 consent 的 process 可能其实是会花蛮多时间的，你要跟病人分析到底他花这1000万他可以期待什么东西这样子。那我当然就是跟骨髓移植一样，我们要做一个 truly 的那个 access 病人的support system 就是他经济能力啊，其实我们还是要跟BMT 一样，要有一点类似做pre-CAR-T 的一些健康检查这样子。那这一张 slide 呢是在2019年的时候，美国他们就是做了一个试调啊，就是对血液肿瘤科医师问说，你们那个在 implement CAR-T 有遇到了最大的困难是什么？那看起来其实最多人遇到的困难就是病人想到要用 CAR-T 的时候呢，其实已经恶化到没有办法使用 CAR-T 了。那要怎么解决这个问题？所以我们就是需要 知道病人其实就是太晚了，所以我们就是要提早的 refer。因为如果你太晚的话呢，病人其实根本没有一个空窗期去停止治疗，因为大部分的化疗嘛都会造成 T cell 的受的损伤这样子，所以你要收到quality 好的 T cell 呢，至少它要有至少2个礼拜的时间呢，是不能够接受治疗，连类固醇也是要1个礼拜，所以你就是要有一个 wash out 的 period。那因为 T cell CAR T 不是你收完细胞隔天就可以回输的，所以它的 manufacture 要30天。那这30天，如果你没有一个很好的bridging 的 options 的话呢，病人在还没有接收到 CAR T， 他就会死掉了，所以太晚也不行这样子。那就是如果像这样子右边这张图，就是如果病人接受越多线的化疗的时候呢，其实病人的 T cell 的 fitness 就越差。那可想而知，他做出来的 CAR T 的 quality 就会比较差一点这样子。那过去就是CAR T 的inclusion criteria， 就 CAR T 的就是 patient selection， 我们常常都会去参考就是 trial 的 inclusion criteria 嘛。那不过随着 post marketing 的 data 越来越多，其实就是病人实际年纪啊，或那个 ECOG 啊，不是实际年纪 biologic age， 就是不是实际年纪 chronologic age 才是他实际年纪，可能病人已经是70岁的人，可是如果他看起来就是身体功能就跟50岁一样，那 performance status 很好的话呢，其实这些病人是可以接受 CAR T 的。那如果 organ function 就是不需要到这么严谨，尤其在 EGFR 的部分呢，就是比较没有这么严谨的，就是 CCR 要大于多少，要小于多少才可以这样子。那以前过往就是太 aggressive 的 disease 啊，或 active 的 CNS disease 呢，这些都是被排除的。那陆续有报道，其实也都还是有病人是有效的。所以到底一个病人怎样才算是一个 candidate for CAR T 呢？如果有人问我这个问题的话呢，我主要会用下面几个方向去思考，就是一个当然就是他有没有 indication 嘛，对。那因为毕竟这个药很贵，如果病人的 financial 是没有办法 support 这个治疗的话呢，我自己个人会觉得我不会跟他提有一个这样子的治疗的 option， 因为这样是会造成他就是病人的家属的负担嘛，就是因为他会觉得就是他没有钱，所以他的家人就死掉了这样子，所以当然 financial consideration 是一个很重要的考量这样子。那 kinetics of disease progression 意思就是跟刚刚前面讲的，如果今天病人恶化的很快，他根本没有 window for leukapheresis， 根本没有办法等30天让他有机会就是等待 CAR T 的制造，那这种病人可能也不太适合。那有 active infection 的当然也不适合这样子，因为第一就是你收的 T 细胞有没有可能会感染，那感染的 T 细胞它在制造的过程中就会一直死，那就会 manufacture failure 嘛。那 active infection 的时候呢，不管是 EBMT 或 ESMO 的 guideline 都是建议不要回输 CAR T 的这样子。那还有其他一些跟 disease 无关的 comorbidity 当然也是要列入考量这样子。那所以到底CAR T 有没有效这件事情就是病人会问你的嘛，因为他拿1000万出来，他当然就希望有效，只是有效这个东西呢，我觉得每一个人的定义不一样。就是如果你问我的话呢，我当然是希望我拿了1000万出来，有效的定义就是我的病就好了，然后对，就好了，就 cure 了这样子。那有一些就是有效的定义是它就 CR 了，CR 看起来 CR rate 其实 CAR T 的 CR rate 都蛮高的，都有70% 以上，可是它有没有durable 的 response 呢？又是另外一回事这样子。那所以评估病人就是适不适合的时候，我主要会往两个方向去思考，一个就是病人他的这个疾病状态，他有机会达到 long term cure 的 的几率是多少，那我就要跟病人解释嘛。那如果没有办法达到 long term cure， 他应该就是要去 bridging 处另外一个治疗，例如就是 allo 的 transplant 这样子。那还有一个很需要考量的就是病人有没有办法 survive CAR-T 的side effect， 就是如果很严重的 CRS 很严重的 ICANS， 这种状况其实我觉得跟移植很像。当病人很严重的 GVHD 的时候呢，他的 outcome 一定也是不好嘛，因为我们需要给他更强、更多的免疫制剂。那第一，他的 CAR-T 的效果就会被打折。第二，那个病人的 immune system 就会变差这样子。那跟大家分享就是我们就是单位就是在评估，就是在处理的这个病人遇到的一些心得这样子。那第一个 case 呢是一个19岁的男性，就年纪很轻的 DLBCL， 那就是 triple expressor， 那一来的时候就 Lugano stage 4， 那他看起来就是一个 primary refractory， 因为在标准的 R-CHOP、DHET 跟 eSHOP 都没有 response， 就是转到我们医院来评估的时候呢，就是一个 disease burden 还蛮大，当时 LDH 也是蛮高899的一个状态这样子。不过因为病人很年轻，那 organ function 也都很好，所以也有经济能力啦，所以他就想要先选择CAR-T instead of allo 这样子。那所以他就在收了血球以后呢，做了一个pola GMOS 的 bridging 这样子。那像这种病人的话呢，其实也不会太 controversial 了，因为它就是一个很 straightforward indication， 很明显很清楚的状况这样子。不过在DLBCL 的在使用 CAR-T 的时候，我们需要考量的一件事情就是，如果这个病人在初诊断的时候，因为初诊断的时候你可能就可以预期这个病人可能不是 R-CHOP 打得下来的，例如这种 triple expressor、double expressor， 然后tumor burden 很大的这种，那您可能就是要先考虑就是它的 sequence of therapy， 就是你要考量一下这样，例如如果你有想要给病人收血球的话呢，最好在病人施打 bendamustine 以前呢，就把他的T 细胞收起来，因为 bendamustine 对 T 细胞的伤害很大，而且比较 long term。那你打了 benda 以后呢，至少要休息3个月才可以收 T 细胞。所以如果今天病人是一个 CAR-T candidate 的话呢，是建议可以病人在打就是benda 以前，或者是打化疗以前呢，先帮他把T 细胞冰冻起来这样子。那就是那个诺华的 manual 也有建议，就是你要做 leukapheresis 之前需要做wash out 的药物呢，的建议这样子，一般大概就是2个礼拜啦化疗。那治疗性的类固醇大概就是7天这样子，那 benda 就是3个月 ，ATG 也是。所以这个是最近我们遇到了一个病人，就是姚医师的病人。那他一来的时候也是一个 high grade B cell lymphoma double expressor Ki67是大于 95%， Lugano stage 4。那时候的 initial presentation 就是眼睛凸出来，然后去切了这颗 tumor， 就是一个 high grade B cell lymphoma， 然后做 PET 看起来满皮肤肌肉，就是很多地方都有这样子。所以像这种病人，他就是很适合在早期，就算是如果他有空间的话呢，就是先收完淋巴球再开始治疗，其实也 OK。如果没有很急的话，因为这个时候他的 T cell 可能是相对比较健康这样子。那这个是诺华 Kymriah 的，就是 leukapheresis material 的 requirement， 就是你要达到这样子的 acceptance， 他才愿意接受。因为我们医院端是提供 CAR-T 的starting material 嘛，所以他对我们当然是有一些要求这样子，这有点类似就是我们要给他的 spec。那他需要的 T 细胞呢，就是至少要1×10的9次方，那 TNC 要有2×10的9次方，而且 T cell 的比例要在3% 以上。那尤其特别有提到，因为 DLBCL 通常就是成人嘛，那成人的 T cell 可能就没有小孩的 T cell 这么好，所以他是建议，虽然 spec 上面是建议说大于1就 OK， 不过其实 DLBCL 他是希望至少大于 1.5 啦，那最多他可以接受到是收到就是4×10的9次方的 CD3 positive 的细胞这样子。那这个也是那个CAR-T Working Group 他们建议的啦。目前大部分的 protocol 呢，其实在成人都是跑到12到15 liter， 那 target 就是希望可以得到5到10乘10的9次方的 TNC。那这个是 CD3 positive 的细胞这样子。那这样子的量10的9次方，做出来就是至少要有0.6到6乘10的8次方，这样子的 cell dose 呢，才是 within spec 的，才是可能有疗效的这样子在 DLBCL。那它 DLBCL 因为毕竟是solid 的，就是固态的肿瘤，可能就比较就是那个 cell dose 就是要比较高这样子。那AL 的 cell dose 看起来就是少一点这样子。那你说其实0.6到6或0.1到2.5，这个 range 很大所以假设我今天收2天收到2.0乘10的9次方分2袋的话，我只把 1.0 只有一包送出去好不好？另外一包我先留着，万一以后病人复发的时候再做。那其实DLBCL 我是没有看到这样子的 report 啦，不过我相信 ALL 的 data 是可以 generalize 在 DLBCL 的，就是越 cell dose 越高的呢，它的 outcome 当然就是越好。那因为这个 cell dose 这个是 FDA approved 的 cell dose 嘛，所以最后 Kymriah 回来是 cell dose 呢 maximum 就是5，就是 for 病人小于50公斤的 ALL， 或者是大于50公斤的5.0乘10的6次方，或者是2.5乘10的8次方，就是看你的 indication 选哪一个，它最多就只会给到你这个 dose， 不会给你更多。那因为它的 range 很多嘛，所以你给它的原料比较多，它其实可以给你的 cell dose 就越高这样子。那当然不会高过这个，因为超过这个它发生 CRS 或 ICANS 的几率就会比较高。可是 within 它当初clinical trial run 的 maximum tolerated dose 来看的话呢 ，dose 越高的，它的 survival 当然就越好。这个很 straightforward 嘛。那 ALL 的是有 data，DLBCL 是没有人这样子做，不过我相信应该也是一样的。所以另外就回到另外 case， 就是这也是最近就是就最近的一个 case 这样子。那病人就是因为做过很多线的治疗，而且他其实有打过5次 Benda。那这个病人呢，他在 pre-test 的时候呢，我们就看起来就是他的 T cell 他的 lymphocyte 就很低嘛，就是只有170几颗。那用出那个 absolute count 去算他的 T cell 的话呢，其实只有239颗。那如果照诺华的那个 guidance 他其实是建议，你收2到4个循环，那假设我们给他收4个循环，其实应该就够了。不过后来这个病人呢，我就是实验室是给他收了15000就是 maximum 15000其实是很多的如果你要 process 15000这个病人的 total TBV 大概就是6个病人 total blood volume 的量，这样子让下来，病人收血球至少会收4到5个小时。那如果是稳定，如果不稳定的话，收更慢的话，可能会收5到6个小时。那收这么久，我们还收了2天，其实收到的细胞只有 1.9乘10的9次方，其实只有勉强达标的。刚刚我有说 DLBCL 他们希望 1.5 以上嘛，所以实验室端可以做的事情就是我们尽可能像这个病人如果有需要，我们再收第3天其实也是 OK， 不过就是病人会比较辛苦这样子。对，那除了细胞的数目，细胞的 cell composition 其实也是很重要的。可是 cell composition 就不是我们可以改变的。那唯一可以做就是我们尽量在病人不要打这么多化疗以前，先把他的细胞收起来，那他可能比较不会这么 senescence， 不会这么 differentiation 这样子。所以那这个当然也是有文献啊，就是这篇是 published 在 Blood Advances， 那它其实 follow 的没有很长啦，就只有 follow 到CAR-T post CAR-T 的3个月。那可以看到，如果病人的 initial 的时候，那个 product 就是你收集下来的 product 是这个图，它的CD8 的 naive T cell 跟 central memory T cell 比较高的话呢，这种病人预后通常会比较好。那看起来就是这个是 progression free survival 嘛。那CD4 T cell naive 跟 central memory 呢，看起来没有 non significance。不过我觉得这个我会有点保留，因为病人只有 follow 到3个月嘛。那 6个月、1年的时候 CD4 有没有差，这个可能有一些 data 就是会显示 CD4 比较多的病人 persistent 比较好，不过 CD8 它毕竟是 cytotoxic 的嘛，所以前面病人如果越早可以达到 CR 的话呢，这种病人预后也比较好这样子。那这一篇是也是一篇就是也是 publish 在就是比较实验室相关的杂志，它是在统计这个其实是 Kymriah 的，就是诺华公司的产品这样子，就是他们去统计病人在 successful manufacture 跟 fail manufacture， 就是他没有办法达到 spec， 所以就 termination 的一些特征啊，那看起来就是病人的 T cell， 不管是 sentinel vial 或者是 leukapheresis product， 或者是 incoming 的 apheresis product， 或者是病人抽血从病人身体里面的 CD3 的分析呢，如果 naive 跟 central memory 的比例比较高，那比较不是 differentiation 的呢，这种是比较容易 successful 的。那相对的就是比较 senescence 的，这个就是一个分化，就是比较的differentiation 的 marker 这样子，或者是HLA-DR positive 的 CD38 positive 的 T cell 比例比较高的时候呢，这种比较容易 manufacture failure 这样子。所以在台大医院的话呢，如果病人已经知道什么时候要做 leukapheresis 的时候呢，我们会 order 一个 PB 的 flow 去分析。那目前是分析这些 marker 啦，就是主要是分他们到底是哪一个 stage 的 T cell， 那我们会把 CD4 跟 CD8 分开来统计这样子。那其实有一些文献是说CD197啊 CD45R CD45R 用来分 CD4 T cell 是比较不这么理想啦，可能需要导入更多的 CD27 CD28 CD57 类似这种 marker， 或刚刚前面讲的这个 KLRG1 这个 marker 就是也是可以考虑这样子。好，那最后就是要来分享一个，就是因为毕竟就是这个治疗它不是100% cure 的，所以当然就是你要就是有预期有病人是会复发的。那刚好我们最近有一个病人他就是复发了，所以来跟大家分享关于 postcard 的relapse 的一些事项这样子。那这个病人呢，就是在接受了，就是一个儿科病人这样子，那其实是蛮 high risk 的，他有一个 TP53 的mutation， 而且是 loss of heterozygosity， 有一点类似那个 Lee-Frommeny syndrome 的这样子的感觉。那病人其实在治疗接受 TPOC 的 protocol 以后呢，其实是 persistent 的 MRD， 直到 reinduction 就是有一点 late intensification 的时候呢，才达到 MRD negative， 可是才 MRD negative 3个月就复发。那后来是在ENO 打了4次以后呢，去做 leukapheresis。那在等待 CAR-T 回来的过程中呢，就是接受了一个 bridging 的TPOC induction to C， 然后病人在做 pre-CAR 这些我标红色的就是都是有人在讨论跟 CAR-T 的prognosis 相关的一些 marker， 例如 pre-CAR-T 的 status， 如果 bone marrow blast 小于 5% 的这种就叫 low disease burden， 通常预后是比较好的，没有 CNS 没有 extramedullary 通常预后也是比较好的，可以接受 standard 的 lymphodepleting 这种预后也比较好。那 CRS 或 ICANS 的 grade 没有这么严重的，通常预后也比较好，所以看起来它应该都是预后蛮好的一些indication 这样子。可是那病人在CAR-T 的 follow 的时候呢day 33的时候就达到 MRD 的 negative， 那持续其实一直 IgG 都是低的，不过因为它都有 regular 的 replacement 那可以看到它的持续都是在B cell aplasia 的情况。那很不幸病人在大概200天左右的时候，那时候其实还是 B cell aplasia 的周边血都没有测到 B cell 这样子，那看起来就是一个 frank relapse，骨髓看起来就是满满的 blast， 那而且这些 blast 看起来非常的vacuole 很多啦，表示 turnover 很快这样子。那 flow 看起来就是一个CD19 negative 的 relapse 这样子。那所以在探讨 postcard 的 relapse 呢，在 AL 的部分呢，主要是有这3个 mechanism。那 lineage switch 的部分在 lymphoma 是没有被报道的啦。通常在 CAR-T 复发以后呢，大部分的医师 就算是lymphoma，我们也会去想要知道病人复发的时候 CD19 的 status， 因为这样你才可以知道他复发的原因是什么。那 CD19 positive 跟 CD19 negative 的复发呢，还是不太一样这样子。那通常 CD19 positive 呢，可能是表示CAR-T 不太 persist， 通常这个 B-cell aplasia 就是一个很好的 surrogate。那 CD19 negative 呢，就表示它已经把 CD19 藏起来了嘛，所以就算 B-cell aplasia 持续存在，它还是有可能会复发这样子。那 lineage switch 呢，就是最糟的状态这样子。那这是2个不同的 group， 都是美国的，就是小儿科很大的统计这样子。那左边这个是 NCI Nilari Shah 团队他们统计了400多个人，在接受各种不同的 CD19 CAR 以后复发的。那看起来 CD19 positive 或 CD19 negative relapse 的 overall survival 没有比较差，不过 lineage switch 就很差。那右边的这个呢是那个 Stanford 的就是这位 Leora Switch 的小儿科医师，他们有成立一个全国美国内的一个 pediatric CAR 的 real world consortium。那他这个 data 呢是有180几个接受Kymriah， 就是左边不是 Kymriah specific， 右边是 Kymriah specific 的统计。那看起来 CD19 positive 的 relapse 看起来预后是比 CD19 negative relapse 稍微好一点这样子啦。不过那我们可以来看一下到底 CD19 negative relapse 就是他们的复发的形态大概是怎样。那这个Pediatric Real World Consortium 呢，看起来就是复发的几率大概是 30% 这样子。那其中做 CAR-T 有 12% 的人是 non-responder， 是完全没有达到 CR 或CR-MRD negative 的。那达到 CR 以后呢，大概有52%的人会CD19 positive 的 relapse， 19 CD19 negative relapse 大概 39% 这样子。对，那这个我没有把 data 放下来。不过分析到底谁比较容易是 non-responder， 还有谁比较容易复发呢？只有一个很有显著意义的，就是 high disease burden。那所谓的 high disease burden 呢，就是 bone marrow blast 大于 5% 这种 hematology relapse， 就是没有达到 hematology remission 呢，就叫 high disease burden。那这种病人就是高风险的 non-responder 和relapse 这样子。那这个就是那个刚刚讲就是 Nilari Shah 团队他们在做各种不同的 CAR 的 relapse 的统计这样子。那他们的统计是follow 这个 follow 比较久嘛，前面这个是只有 follow 380天，这 follow 了30个月，看起来会 relapse 的大概其实是44% 这样子。那44% 当中 CD19 negative relapse 也差不多40几%这样子。那 lineage switch 发生 relapse 就最快，大概 median 是65天 ，CD19 呢大概是148天，CD19 negative 是148天 ，CD19 positive 是244天这样子。那我们想要知道就是谁比较容易发生 CD19 negative relapse， 那他们的统计看起来年纪比较轻的CAR type， 他这里就写说 CD28 是比较少发生 CD19 negative relapse 的，所以这个病人他是接受 4-1BB 的嘛，不是 CD28 的。它比较就是看起来是 4-1BB 的比较容易发生 CD19 negative relapse 这样子 high disease burden 的blinatumomab non-responder 这种病人比较容易发生CD19 negative relapse。那 lineage switch 它是预后最差的，那它其实就是特别多出现在 KMT2A rearrangement 的病人身上啊。那一样就是如果 high disease burden 的这种病人他们复发的几率就比较多。看这里只有4个人有机会达到CR 这样子，那就是超过一半都是发生复发这样子，而且很多都是lineage就是那个发生 lineage switch 的这样子。那最后就是回到就是 CAR-T 的 implementation， 其实就是需要很多的团队，就是很多的专家一起来就是协助的，就是那其中很重要，就是因为我们是提供 material 的那个 supplier 嘛，所以其实厂商 manufacturer 呢对我们是有期待的，所以就是像台大医院有时候会接收到外院就是国外的一些clinical trial 的询问，他就会问我们说我们是不是有 JSIC， 有没有 FACT 的认证这样子，因为 因为有认证，他才会觉得你的 cell 是有 quality 的。IEC 就是所谓的 immune effector cell。那还有一件事就是要做 CAR-T 呢 ，FDA 美国 FDA 是要求要有所谓的 REMS program， 就是 risk 什么 mitigation 的 program 这样子，对，就是 risk assessment mitigation program， 类似这样子的东西。所以还这个其实不是只有美国，同样在台湾卫福部也是这样子要求的，所以我们也是要做 post marketing 的 data reporting， 目前是统一都 report 去CIBMT， 未来也会 report 到台湾的registry 这样子。那这就是说这个是 FDA 要求的，那台湾 FDA 也就是当然也有比照办理，就是我们要有所谓的 REMS 的 program， 各种 CAR-T product 都要。那 Kymriah 的话呢他们怎么所以你要 start Kymriah 在医院里面就是要接受他们的 REMS 的 training， 就是所有相关的人员护理人员、医师、药师都会来一起坐在就是去上课这样子，上他的这个 risk assessment 这样子。那对，这是理想啦，就是 CAR-T working group 建议的 best practice of experience centers 呢，就是 weekly 要有人去 review，monthly 要有 IEC 的 portfolio， 那我们要 review 我们的实验室我们的 quality， 那每一季要有 fact 的 review， 就理想上就是未来我们希望可以走到这一步这样子。那就是回到今天的主题。这个 successful 的 CAR-T implementation 就是需要一个 multidisciplinary 的 team， 那每一个角色呢，其实他们都有他们需要准备、需要了解、需要参与的部分这样子。那病人本身呢，他其实也是 part of the team， 还有 caregiver， 因为毕竟这个治疗它的 long term effect 很长，有一些人可能到100天，甚至回家以后持续都还是有一些症状，他需要就是自己 monitor， 再跟医师回报的。所以对，这是我最后这张 slide， 就是对，就是需要一个 it takes a village， 对 to successful implementations of CAR-T 这样子。谢谢大家。
好，谢谢李医师的 report。那线上的问题，好，有一个问题。就是有医师询问，就是针对 BTKI 的一个使用，你知道 BTKI 对那个 CAR-T 的收集可能会有一些影响，那有建议的 washing out period 吗？
有，等我一下哈。其实就是我很常被那个临床医师 consult 的就是 wash out 的这些状况，所以我都没有背起来，所以我都直接把那一张图打开。在哪里？在 workshop 在哪里？workshop 在这里 ，BTK inhibitor， 上面竟然真的没有，真是囧。好，没有的话呢，如果上面没有的话呢 ，Novartis 的建议官方建议是，最好是可以 wash out 5个 half life。5个 half life， 每个药物的5个 half life。那你说5个 half life 是多少？其实我们不太知道。我觉得最好就是2周，对，14天。那讲到这个，我也有一个可以分享的，就是像之前我们有个病人呢，他是打完 Pola 以后需要收，那有文献是说 Pola 的5个 half life 是3个月 ，Pola 可能比较长效，所以要等3个月以后才可以收。不过这件事情我后来有跟诺华内部的人讨论，因为 Pola 它本身不会伤害 T 细胞，所以原则上，就是因为 Pola 就是伤 B cell 的嘛，理论上 T cell 是没有 CD79B 的，所以我们就没有等3个礼拜再收啦。不过大部分的药呢，他们都是建议要 wash out， 那个5个 half life 这样子。那其实 BTK inhibitor， 如果林建廷老师还在，不知道他等下可不可以帮我 comment。在我看一些西药的文献，其实它好像对 T cell 的 fitness 是有一点点帮助的，就是它可以增加 T cell 的 fitness 的。所以是不是一定要停这个东西呢？我觉得就是可以讨论的这样子。
建廷你被 Q 了，你要不要回答一下？
这个问题其实很有趣，因为如果是针对 BTK inhibitor，我没有看过真正 让我觉得幸福的指引，说什么时候要停，什么时候要用回去。但是我可以跟大家报告，就是说，其实我觉得 BTK inhibitor 是一个很神奇的药，它在绝大多数看过的实验里面，尤其是像动物实验或者是临床的使用经验上，我觉得 BTK 的 inhibitor 好像可以帮助CAR T，而不是抑制CAR T。所以其实有一小派的人，比如说在治疗 CLL 或者是治疗 mantle cell lymphoma 的时候，其实会建议就是 CAR T 在回输的时候就把 BTK inhibitor 就把它就是并用，不要停，就是并用的意思哈。我不太确定这样的做法能不能是大多数医师能够接受，但我觉得它是一个很有趣的想法，而且事实上看起来，我觉得啦吼，撇开当然不谈的话，我觉得我可能会尝试，我会想要尝试这样子的做法，因为我觉得它是正面的。谢谢。
谢谢老师。
第二个问题其实是技术上的问题就是关于我们在做 phoresis 的时候，我们的 minimal blood flow 对收集的效率会不会有影响？应该是这样子一个问题。然后当然会有 hypokalemia 啦，那 hypokalemia 的时候，它应该是说在 CAR T 收集的时候，跟我们在做干细胞收集的时候，会不会有什么不一样的处置模式？
这个部分的话呢，其实跟干细胞收集是很像的。那我觉得在成人比较不会有这样子的疑虑，小孩其实比较是一个 issue 啦，尤其是我们有收一个2岁的，他就真的要run很慢，他收2个 total blood volume 呢，就是两个。就是2倍的 total blood volume 呢，是成人可以收4倍，同样的时间，因为你拉太快，病人就 hypotension 嘛，就会 shock， 所以就只能够很慢。那成人的话呢 ，minimum 血库跟我说分享的经验是，他们不会让超过低于60，因为太低。不会低于30，对不起，讲错了，大部分是让60，因为小于30有时候会 clot 这样子。那收太慢的话，会不会影响apheresis 的efficacy？这个就是要看为什么不能够收很快。有时候不能够收很快的原因是因为病人的关系，有时候不能够收很快，或者是flow rate 是因为有卡。机器有卡，这种如果有卡机的话，它的 efficacy 就会差就是会差这样子，所以我们就是要给如果流很慢，我们就是要需要比较多的anticoagulant 就 ACD 这样子啦。那 hypocalcemia 我们一律都是就是补钙这样子，所以对，那当然还有病人是就是补了还是会有症状，还是在抽筋，还是会麻，那我们就是边补边收这样子。那如果真的不行，可能就是看他可以让多少，大部分都可以 tolerate 3个循环量，就是3个 total blood volume 的循环量这样子。
好，那我想应该跟一般我们在做干细胞收集应该不会差太多啦。那只是差别在病人可能是病人，那有时候身体比较那个是比较小的病人可能会有一点不一样的。我想大概就这样。
是。
好，建平有问题。好，
我提一个补充的那个想法给大家哈，就是我们比如说实验室端然后 CPU 端在生产 CAR T 的时候，我们到底用多少的 T 细胞去执行 CAR T 的生成？大家有没有想过这个问题？真的是1×10的9次方的 T cell 吗？其实不是的。跟大家报告，其实我想大部分的公司应该在生产 CAR T 的时候，其实只需要1×10的8次方，最多了，大概最多就是1×10的8次方的 T 细胞，活的 T 细胞去做生产就好。好，那如果只需要100个 million 的 T 细胞，那为什么像诺华一开始要求1×10的9或者是更多？其实跟大家报告，因为病人的 T 细胞真的不健康。当我们经过冷冻，我就把它就是液态氮，然后就冷冻，然后在解冻的过程当中，其实我们还蛮常看到，就是解冻完之后的 cell 的 recovery 哈，其实可能会剩下一半。那还有看过更惨的，可能剩下1/3、1/5， 就是会有这么凄惨的状况。所以为什么一开始诺华可能会要求要比较多的 T 细胞，其实是为了要避免解冻完之后细胞就大量的死亡。那所以其实我觉得那个是厂商预留自己一个台阶啦齁。如果你真的给它刚刚好1×10的8次方，那万一细胞死的太多的话，那就没有办法用来生成了。那至于为什么我们要怎么样能够让病人的 T 细胞在一开始的时候我们就知道这个人可能将来预后会比较好。我们如果想说 T 细胞的量跟 T 细胞的值来做评估的话， T 细胞量我们可以用 absolute lymphocyte count 来做简单的代表，或者是我们可以直接去用 flow 方式去算 CD3 positive 的 T cell 有多少，这个大概是可以做量上面的一个评估。但是值的评估一般我们大概就比较没有办法做。那所以说刚刚是会有提到说 CD8 positive 的 TSCM 的那个百分比，我觉得勉勉强强也许可以当作是一种量的间接的指标。再来 leukapheresis 的时候呢，我们真正能够收取到那个 product 里面有多少 T 细胞，我们来讲我觉得那有点像是量的指标，就有点像我们在讲说自体移植之后的那个病人不应该说我们要收病人的自体的造血干细胞的时候如果病人的platelet 的 count 比较好，所以我们容易收到比较多的 stem cell。我觉得隐隐约约有那种概念，就是如果我们在 leukapheresis 的时候收到比较多的 T 细胞，通常暗示 T 细胞的品质通常也比较好。也许它们关系没有那么的线性，但是应该某种程度是成正比的。好，谢谢。
好，你现在已经8点56分，大家有没有什么其他的问题？好，如果没有问题，我想是会提供很多就说很多很实际的经验。那我想大家日后应该还会有更多的机会，就是那个能用到 CAR-T。那我想我在这里就把主持棒交给李启成医师。
好非常谢谢柯医师跟智慧的第二场那我们今天2场都非常的热烈都欲罢不能那我们今天还是很感谢诺华的部分的赞助那因为现在就是健保因为还没有给付 CAR-T 在台湾所以我们当然今年都很少。那所以在骨髓子学会这边呢，我们当然也跟柯博森前理事长也成立一个 CAR-T 小组尽量就是多多做一些教育的打基础的工作。所以如果各位会员们有听到很不错的 speaker 啦不管是国内或国外的我们就跟 feedback 学会我们就来邀请那诺华虽然也常常赞助我们学会，但是诺华也是很 open minded 因为我们就是把这个 academic 的氛围把它带起来那也可以去请不同的非诺华的产品。那甚至我们国内像一些林建庭医师还有一些很专家我们 local academic CAR-T 我们可以一起来学习来教育那今天就在这边跟大家说个晚安谢谢大家拜拜。